This conference will now be recorded.
So, dear students, welcome to the Obstetrics EMQ session 2. So, again, this will contain like 50 EMQs of obstetrics. Okay. So, okay, welcome. So, now this is the question number 1 that you have been called to see a primate 38 weeks of gestation who is fully dilated. A CTG, they show that the variability is 145. Baseline 5 to 10, variable deceleration 60 beats per minute lasting for 60 seconds. And they are present over 50% of the contractions. So fetal head is 2/5 palpable, no caput +1 molding. So what are your thoughts? What you will do? So the patient is like variability is
Variability is okay, but decelerations is in suspicious CTG
yes,
concerning characteristics.
yes. So there is one amber feature is there, that is of uh, deceleration. So one amber feature makes CTG suspicious. So what to be done?
Yeah, D category 2 CS. Head is also 2/5 palpable.
Yes, but before you proceed to cesarean section, you have to do the conservative. So the question is from previous guideline, and the answer is FBS, basically conservative. They want that how much time they can get. So like such kind of option is not there in this. So there are repetitive deceleration with concerning feature less than 30 minutes. One number point, suspicious CTG, ideally conservative, and if it is not working, then yes, you are very right. Then it will be uh, cesarean section for the maternal reasons. No, so for the fetal reason, then it will be D. Okay, this will be followed by D, but not now. D will not be there, but the question framing is according to the answer FBS. Okay. Okay, so this is the amber feature, and our patient have got first repetitive deceleration with concerning feature less than 30 minutes. So this part our patient have. So if the according to the new guideline, if the suspicious CTG with no concerning feature, so full set of observation. If acceleration is present, then fine. Otherwise, conservative. Okay, and conservative measures. If any after conservative, if any suspicious feature is there, then answer like if in the scenario we did, there is any high risk factor like slow progress, sepsis, or meconium. That time answer will become conservative with the expedition of birth, but conservative will be fetal scalp stimulation or expedition. Okay, so this is from the new guideline 2023. So now the patient, nullipara patient at term, abnormal CTG, fully dilated, -1 station, occipito-posterior position. CTG shows tachycardia of 180, late deceleration more than 30 minutes. So late deceleration more than 30 minutes and tachycardia. What does it suggest?
Pathological CTG.
Pathological CTG. And where is the station?
-1.
So answer is
B category 1 CS.
yes, category 1 CS. Category 1 pathological fetal heart tachycardia, late deceleration for 30 minutes. More than that, pathological CTG, expedition of birth, fetal reason, so category 1 cesarean section. Very right. So this is from the new guideline. If the CTG is pathological, urgent review, exclusion of the acute event, start conservative. If still pathological, then expedition of birth. So now here you have been called to the room with a primary, late first stage of labor, have deceleration for past 5 minutes, and baseline dropped 138 to 95, not recovered. So prolonged deceleration. Single prolonged deceleration. More than 3 minute time.
Expedite delivery.
W, conservative followed by expedition. Now this is the answer. So single prolonged deceleration more than 3 minutes. Urgent obstetric review. Rule out acute events. Identifying the cause. Undertake conservative as indicated. Make preparation for urgent birth. If expedition of acute bradycardia persists more than 9 minutes, then reassess an expedition. Got the answer?
Hmm.
So it is you have to start conservative. You have to review patient again after 9, like whether the patient come back to normal within 9 minutes. CTG is fine, then it is fine. But if after 9 minutes there had been sort of no change, then the birth has to be expedited. This is
Ma'am, I want to ask a question.
hmm
Ma'am, here it's said single most appropriate answer, and conservative is the next thing to be done. So, single most answer and the next step to be taken, both the same.
okay. See, basically, single most appropriate action you will like to either initiate monitoring or what you will do. Okay, see, basically, you should know what is the answer, how to manage if the 3 minute bradycardia is there. Okay, in this question that we are doing, there is no acute event,
Hmm.
nothing is going on here. Only sir single bradycardia is there. So directly going before directly go for cesarean section, there has to be conservative measures.
Okay.
Okay, directly expedition because there could be possibility. See, they are saying if there has been acute event, like if your scenario shows cord prolapse, abruption, uterine rupture, then immediately you will answer expedite the birth.
Hmm.
Okay, but in the scenario, this kind of situation, acute event is not there. So you
Hmm.
will make preparation for urgent birth, and you will review patient again. If it is with the 9 minutes, same thing, then you will expedite. So here expedition cannot be there directly. Is it clear?
Yes.
Apart from this, it is important, your concept has to be clear because the question formation in exam is correct rather than here. This is the management for single prolonged deceleration more than 3 minutes. Okay, now here
Hmm.
another question. Patients are in the labor, whether need fetal monitoring, single most appropriate action that you will take. So 31-year-old woman subjected to CTG because fetal heart rate abnormality on intermittent auscultation. CTG has a baseline of 150, 185 for 50 minutes. Only one feature is there. Maternal temperature was checked, normal. So no maternal tachycardia, okay. Patient is left lateral position is done, fluids mobilization, tachycardia persisted. No acceleration, no deceleration. So what to be done? Only one red feature not responded to, not responding to
Not
conservative measure.
conservative measures.
So conservative measures are already being taken. Patient has got, you know, nothing. Then it has to be followed by expedition. But as the formation of question is from previous guideline, the previous guideline answer was FBS, basically to buy time. Okay. So fetal heart rate, if it is more than 160 for 1 minute, it would be red feature according to the new guideline. So we have got one red feature and the patient is not responding to the conservative. So we have to do expedition. So you have a patient with confirmed diagnosis of PPROM, 27 weeks, 6 days. Patient is not contracting and CTG is normal. What will be single most appropriate treatment?
Option E, like H,
Very nice. H. So you will give steroid and antibiotic.
antibiotics.
Answer H. And this is a summary for PROM. Your diagnosis is confirmed. So you have to give erythromycin 250 milligram 4 times daily for 10 days. If your patient is allergic to erythromycin, you will offer penicillin and steroids. So this is the answer H. Very nice. Now the patient uh, is admitted with 22 weeks. He is slightly irritable uterus. Temperature is fine. Urine is negative. PS shows bulging membrane through cervix. What can be done? So what can you do if the membranes are bulging?
Cerclage, but here to it's 22 weeks only. V,
Yes, cerclage would be the answer because it will be rescue cerclage. You know, a prophylactic when the patient has no symptoms. Are you getting? Here it is bulging membrane. So it is not prophylactic. It is emergency cerclage or rescue cerclage. This is the emergency cerclage or rescue cerclage according to the guideline. It is a measure in case of premature cervical dilatation with exposed fetal membranes in vagina, what our scenario says, and it can be done till 27 plus 6 weeks of gestation. So both of the criteria are fitting in this question. So answer is emergency or rescue cerclage. Is that clear?
yes.
Now here the patient like is on LMWH. So what they want you management with in labor uh, with continuation after delivery LMWH. So 24-year-old woman has a DVT 28 weeks. She is taking maintenance dose of LMWH. Planned for induction. What we will do?
D. Option D. D for Delhi.
Yeah, very nice. So when the patient is on a therapeutic dose, we have to stop 24 hours before. So this is the GTG summary. Uh, Stop therapeutic heparin 24 hours before labor induction. Again, okay, here I have given the answer already. So this is patient on 29 weeks, therapeutic dose of LMWH. He is admitted for elective cesarean section under spinal anesthesia. A epidural analgesia. Cesarean was performed under spinal anesthesia. Is on therapeutic dose. We have to give LMWH 8 to 12 hours after regional anesthesia. Okay. God, I have put the answer again. So, a 26-year-old woman, therapeutic dose of heparin, booked for cesarean section at 39 weeks. So, what should be the answer? What should be the answer? Patient is for cesarean section.
It is also D. Option D.
Yes, it will be option D. We have to stop it 24 hours before.
24.
Yes. Okay, now here it is about HIV. So 30-year-old woman, 13 weeks pregnant. She's booked last week. Her HIV screening has come positive. She counseled for the result, would like to continue CART from 14 weeks of gestation. So what should be the answer? So, what
F.
is, huh?
F. Resistance testing.
See, resistance testing is done when the patient is already on CART.
Oh. Then option B.
Then
B for Bombay.
what about infection screening?
Oh, yes.
So screen for genital infection, baseline CD4 count and liver function test.
Hmm.
Okay, because you are seeing patient for the first time. So whenever
First.
the,
Yes.
yeah, when the sexual health screening is recommended for newly diagnosed HIV, and yeah, rest and the patient who have CART, um, then the resistance testing is done. So woman is 16 weeks, she is taking CART, liver function tests are normal. Any guess?
L.
Very nice. Answer is L. So the patient is newly diagnosed, then uh, like So viral load testing done 2 to 4 weeks after starting treatment, every trimester, 36 weeks, and delivery. Okay, so this is about again HIV. So patient with 37 weeks, rupture of membrane has been there. He started CART on 27 weeks. Viral load is 80. So how would you manage? If the patient has HIV and shows high RNA copies, rupture of membrane,
Yes, B. Antibiotic prophylaxis for group B streptococcus and considered as yes.
uh, and it should not be considered, it would be immediate. And you have no
Not
time for to give GBS prophylaxis. Though
hmm.
ideally it should be
Then
given, but the here it is considered, but you have to immediate cesarean section because the membranes are ruptured. You can't wait.
hmm.
Okay, so yes, answer is N. So this is about spontaneous rupture of membrane. C. Immediate induction or augmentation of labor is recommended if the patient has pre-labor SORM. If the copies are 50 to 399, immediate CS. Because of that,
Hmm.
immediate CS is the answer.
Hmm.
Though answer you gave is also right, but we can't wait for GBS. 28-year-old woman, 37 weeks of pregnancy, rupture of membrane. 14 hour ago, she waited to deliver vaginally. Viral load is 2000 copies, contracting infrequently. Cervix is 3 centimeter dilated. Again, so it has to be immediate cesarean. Apart from this, what should be added in the answer? High viral copy, more than 1000 in labor. What you will do? What you will give?
GBS prophylaxis.
Yeah?
GBS
Hello?
prophylaxis. Hello.
Oh God, yeah. Patient has got HIV so much high. So IV zidovudine. IV
Yes.
zidovudine and immediate section is the answer. So the two things have been asked. High viral load and rupture of membrane. That means immediate delivery, immediate CS. Third is, second is high copies.
Hi.
So
Yes.
this is the intrapartum use of zidovudine. Women with a viral load of 1000, more than 1000 who present in labor with rupture of membrane or admitted for planned cesarean section. So you have to do immediate cesarean from here, and you have to add IV zidovudine from here. Okay. Was reluctant to start HRT till 30 weeks. Viral load after 4 weeks is 12,000. What they want. So very, very high viral load. And she is 36 weeks. Same answer.
Same answer. Yes.
Same answer. Rupture of membrane with higher viral load. So immediate CS and 0D. Okay, this would be easy now. So you have to do the classification. So the patient is doing regular ultrasound and a DCDA twin, 26 weeks. Latest scan shows discordance of 25% in the velocities. So what will be the diagnosis?
A.
Yeah, very nice. A is the answer. So this is a definition. Growth discordance but positive velocities in both umbilical arteries. So it is stage 1. Okay, so here EF MCDO twin, weight discordance 15%, DVP is 1.5, another twin DVP is 8.5, bladders are seen, MC are normal.
The option E.
Hmm.
TTTS stage 1.
TTS stage 1. So this is TTS stage 1. If this is if the bladder of donor is not visible, then it becomes 2. So we are dealing with TTS 1. Okay. So MCDA 24 week shows discordant growth, oligo in one, poly in one, and abnormal uterine artery Doppler with reversed flow, inductus venosus, presence of ascites and pleural effusion, scalp edema.
H. Stage 4. TTTS.
Yes, it has to be stage 4. And if one of the fetus dies, then it becomes stage 5.
5.
Okay, so 20-year-old pregnant with monochorionic monoamniotic twins is 32 weeks and uncomplicated pregnancy. When you would plan, what you will plan for them?
I.
I is uh, I is good, but what will be the mode of delivery in MCMA?
Caesar. Money F. F.
F mane K.
Oh, I didn't see that. Yes, K. K. Ma'am. Yes.
Because cesarean section is there, mode of birth,
Hmm.
time of birth, and
And
steroid.
time.
All three things they
Oh,
have
very
given.
good.
So MCMA delivered by cesarean 32 to 34 weeks. Why? Because they will have umbilical cord entanglement and the mortality is very high. Okay, so this is the answer. So 30 to 4-year-old woman, gravida 3 para 2, have MCGA twins, a serial ultrasound at 34 weeks. Both twins are breech. Both are non-cephalic. So what you will say? When the delivery has to be done for MCDA,
Oh, 26 weeks onwards.
and it has to be done by cesarean section.
Caesar section towards M.
Yes. So N is the answer. Now DCDA delivery 37 weeks, MCDA 36 weeks, TCTA 35 weeks, MCMA 32 to 34 weeks. Okay, the patient has hemophilia. Single most appropriate intervention you will initiate. The patient is a carrier of hemophilia A. Desmopressin was given because the factor were 0.35 international unit per ml. Rechecked after 1 week, still low. What you will do? Not responding to desmopressin.
A or
The patient is not responding to desmopressin. So what you will give? You will give directly factor.
Factor
So which
8.
N, factor 8. So recommended factor 8 to be given if the levels are obtained with desmopressin are insufficient or if there is known non-response. Okay, so this is recombinant factor if the desmopressin are insufficient. Hemophilia B, patient miscarriage, going for ERPC, factor levels are low. What you will give?
R. Tranexamic acid activity. No.
Hmm?
Then I will give factor 9. 9.
Yes, you have to give factor 9 because ERPC you are going to take patient right now, so you have to build up the factor. Okay, this is the patient diagnosed with a breech. Single most next step in their management. Next step 30 primi gravida with, in the breech presentation. Antenatal assessment confirm that the condition are satisfactory for breech delivery. She is given epidural, dilated with breech at spine after 2 hours. She is still stuck at spine. What you will do?
G.
Yeah, very nice. Because there had been no progress, so you have to consider cesarean section. Now here the patient in labor with breech presentation. She wants vaginal birth. She has been assessed antenatally. Baby weight is 3.2 kg, 6 centimeter dilation. After 1 centimeter, she is contracting less. So what you
Then
will do?
C. Comments oxytocin.
Yes, because according to the new guideline, there should be 4 contraction for 10 minutes time. So the patient is breech, contracting 3 to 4 in 10 minutes, 5 centimeter dilated, reactive CTG, 4 hour later, 7 centimeter dilated. CTG is reactive. So what to be done?
L. Reassess in 4 hours.
Yes. Now the progress is fine only. So the normal labor to continue. And in first stage, we do PV after 4 hours. Okay. So in first stage of labor, 4 hourly, PV has to be done 4 hourly. Okay. Here, uh, like the patient is multipara, spontaneous labor, uncomplicated pregnancy. Labor progresses very quickly. After 1 hour of rupture of membrane, he become hypotensive, hypoxic, developed seizure, and cardiac arrest. What is the diagnosis? So keyword is rupture of membrane.
Amniotic fluid embolism.
Yes, amniotic fluid embolism.
When it results in seizures.
Yeah, it can happen. There would be like hypotension, hypoxia. Later on, there could be bleeding also.
Okay.
So it is amniotic fluid embolism. Now the patient is 40 weeks. Epidural is given. Labor progresses to full dilatation. She started pushing. 45 minutes after pushing, she delivers. She collapses. Tachycardia, hypotensive, left tracheal deviation, reduced air entry on right side. So what has happened?
Tension pneumothorax.
Yes, tension pneumothorax. So 38 weeks of the patient with severe headache. Headache was so severe, never explained it before. Pregnancy was uncomplicated. Blood pressure is fine. After admission, there is a neck stiffness followed by temporary respiratory arrest. She is intubated and transferred to the respiratory intensive care unit. So what is the diagnosis?
Hmm. H. Ruptured aneurysm.
Yes, ruptured aneurysm. So, patient, what is the symptoms of ruptured aneurysm? Patient would have sudden onset severe headache. There would be stiff neck, and then there could be associated blood vision, seizures, drooping of eyelid, or dilated pupil. Or so this will be the sign for ruptured aneurysm.
Hmm.
Okay, so 30-year-old woman for for a cesarean section for the fetal distress at 36 weeks for fear of uterine rupture. On opening it, it is a placenta percreta. So what should be the next step? The percreta is there. What to be done?
Ideally G, but it's saying it's preparing for fetal distress.
Now fetal distress. Yeah. So you can't wait so much. So you have to do. The cesarean has to
B.
be done.
B.
What
No,
is B?
L.
Yes. L is the answer. Why? Because the cesarean, you have to deliver the baby and you can proceed with the
Hmm.
hysterectomy because cesarean section is done by your consultant. You are with your consultant already.
Hmm.
So many of the students will do mistake. Some will do call for help and this and that, but the consultant is already there. So and it is
You and your consultant.
fetal distress. So you have to deliver the baby and you can go proceed with the hysterectomy.
Ma'am, N, should N be a better option?
And
N.
this
N for
um,
Mumbai.
vertical uterine incision, deliver the baby, proceed with the hysterectomy. Why you will do bladder wall resection if the
Ma'am, it's
in
saying
question
percreta.
percreta means all three layer of uterus is involved. They're not
Okay.
saying bladder is also involved. If the
Okay.
question if the question mentions anything that the possibly the bladder is involved, then the answer will
Hmm.
become M.
Okay. Okay.
So the cesarean section is done and the placenta is morbidly adherent. Left in situ, there is a risk of the hemorrhage. So what you will do? So you have to monitor the patient, isn't it? How would you do?
Hmm. Hmm.
There is one option with the
J, ma'am.
see they have already done the cesarean section.
Hmm.
Okay, so placenta left situ that is already been done. Now it will
Oh,
be regular review. They're asking post-op.
oh, acha, acha. Hmm.
Okay, yeah. If they say they are doing cesarean section, then the answer will become J. If they say
Hmm.
that has already left in situ, that means cesarean
Hmm.
section is done, then the answer will become N.
Okay.
Because of that, we have to read in between words and we have to understand what the question says. Okay, this is now easy question. The patient, you have to speak about the single position. So multipara in Breech, fully dilated, and now she started pushing. You're about to position her for the maneuvers. What will be the position?
H, semi-recumbent.
Yes, semi-recumbent, and this is the recommendation by guideline, either semi-recumbent or all four. So 32-year-old woman, no sorry, intraoperatic cell salvage for RH negative mother. She has been given 1500 international units of anti-D, and after re-infusion of salvageable cells, blood group of cord is unknown. What you will do?
M. Sorry, H. Hmm. Fetal-maternal hemorrhage testing 30 to 40 minutes after infusion.
Yes. So if the intraoperative cell salvage is done, then minimum dose of 1500 is given, and the immediately at the maternal sample to be taken for the estimation of FMH 30 to 45 minutes.
Hmm.
Okay, so 33-year-old woman with normal bleeding started bleeding heavily. 4 liters of blood is given. MOH is activated. She is transferred 6 units of blood cell. So what to be done? Now you will give FFP.
Hmm. D.
Yes, D is the answer. FFP should be given after 4 units of RBC transfuse. FFP to be given at the dose of 12 to 15 milliliter kilogram. Or
Hmm.
this is also another 4, 6 RBC and 4 FFP. If the results are not there, so both of this you have to remember. So the woman at like single best method to deliver. So primary gravida 34 weeks, full dilatation, occipito anterior at ischial spine. The patient has got late deceleration, persisted for last 30 minutes. Vertex is +2. How you would deliver?
Naval bands forceps G.
Hmm. Very nice. Late deceleration, mid cavity, preterm, forceps with mid cavity, so navel Barney G. So these are the instruments. This is the outlet Wrigley, and see B. This is the navel Barney. This is the navel Barney forceps. This is important for you, not for part 2 people, but part 3 people. Navel Barney is given in the exam, and this is your keylets. These are the choices where ventouse is preferred, and these are the condition where forceps is preferred, because one time one of the students sent me message where ventouse should be put or where forceps. So read this table, you will have an answer. So the patient has thrombocytopenia. She is fully dilated. Vertex after is +1. Occipito anterior position. So what to be done? Patient has thrombocytopenia.
A.
There is no fetal heart problem.
Oh, then B. My only low cavity forceps is allowed.
No, no, cesarean section, but it has
Yes, my B.
it
We
has
can't do mid cavity forceps.
yes. So you have to take
Hmm.
category 2 cesarean section. See,
Hmm.
category 1 section is done when some emergency happens or pathological
Hmm.
CTG.
Hmm.
Here
Hmm.
there is no problem, so you can
Hmm.
deliver category 2.
Hmm.
So primary gravida 40 weeks of pregnancy, labor progressed to full dilatation, epidural sited, fully dilated for 2.5 hours, actively pushing for 30 minutes, fetal deceleration, head at spine, in occipital anterior position. What to be done?
G.
Huh?
G. Our head is occipital anterior. So they will bounce.
Uh, Fetal heart deceleration is only for 20 minutes. So we can wait. Maybe the further progress may be there. Because pushing is only 30 minutes. You can give more time for pushing. Because the patient is at
Ma'am,
epi. Yeah, yeah.
2.5 plus 30 minutes or 30 minutes is included in 2.5 hours.
See, it has already been a confusion. Passive stage is included according to the operative delivery guideline, but it is not included according to the NICE guideline. So this will be always a query. But okay, but the basically the what the question says. So like delivery ideally has to be done within 3 hours, but here the patient
Hmm.
is on epidural, so you can give more time, isn't it?
Hmm.
Patient is on epidural, then 1 hour more can be given, and
Hmm.
late deceleration only for 20 minutes. That is not a problem. Deceleration has happened because the hypotension caused by the epidural. So you can wait and watch here. But the question is from the previous guideline. Here, wait and watch option will be what? FBS.
Hmm.
But that option is not there in this. That option has
Let's.
that option has been removed from the guideline. So ideally, you have to wait so that she can push more, and you have to keep continue observation. Okay, otherwise delivery. Clear?
Okay.
So the patient has tonic-clonic seizures after normal delivery. AED dose increased for control. She is breastfeeding, likely to go home 48-hour delivery. So what will be the management? Dose was in the
G.
clue is
G.
what
G.
is it?
You will reduce the dose.
Oh, what is written in your guideline about this postnatal? The review of the dose has to be done at what days?
7 days, 10 days.
10 days. So this is from your guideline. If AED
Hmm.
dose increases in the pregnancy, it should be reviewed within 10 days of delivery to avoid postpartum toxicity.
Okay.
Patient is on lamotrigine, deliver vaginally, and she's concerned that what will happen, the effect of medication on the cognitive behavior outcome of her baby.
B. Breastfeed and continue medication.
Yes, breastfeeding and continue medication. Breastfeeding has not shown to have any effect at 3 years of age in the children exposed to in utero lamotrigine, valproate, phenytoin, and the carbamazepine monotherapy. Okay, so this is about chickenpox now. So the primary gravida seen by the GP with chickenpox, she has rashed 18 hours back. She's a smoker, coughing throughout pregnancy, currently 22 weeks. No sign of chest infection or other symptoms. This is an easy question. So what you will give her as a treatment?
Acyclovir oral.
Yes. And the patient has a risk factor, smoker. She's in a
To
second.
refer to hospital.
Very nice. So answer is
Yes.
S. S is the answer. So the patient has
Ma'am,
gastric. Yes, yes.
ma'am, in option S, it should be for 7 days or 5 days.
Uh, it is no, it is right only. 800
Hmm.
milligram 5 times daily for 7 days. It is not TDS. It is 5 times
Hmm.
daily.
Okay.
Patient has gestational diabetes, booked for induction of labor. Diabetes is well controlled. Now at 35 weeks, she had a rash with a typical of chickenpox, seen by her GP and referred for the hospital review. What is the appropriate management?
If
Uh, you, you want, yes, a
no,
delivery.
no, no.
Yes, yes, this is the answer. F is the answer.
Hmm.
You have to delay the labor by 7 days. So
So,
this is the answer. The planned delivery should normally be avoided 7 days after appear of maternal rash to allow passive transfer of antibodies from mother to baby. So F is the
hmm.
answer. So antenatal, now here the baby is small for gestation. So 32-year-old woman comes in antenatal clinic for suspected SGA.
Hmm.
Scan diagnosis, umbilical artery normal.
K.
Yeah, K is also an answer. E, E or K, both could be the answer. This is from the new guideline, USG biometry and umbilical artery, Doppler. This is a optimal method of surveillance SGA. This is a new guideline. Yes, so the K is the better answer. Okay, so here the patient at has assessed for high risk for SGA. Serial ultrasound planned. First one is 26 weeks. She has scan shows everything is normal. So again, the answer would be K. By every 2 weeks, the patient has to be seen. Biometry scan and also Doppler. Okay, now here the patient has an selective cesarean section for placenta previa. Following removal of placenta, started bleeding. Various bleeders were overrun, sutures were put. She transfused 6 units of blood. FFP is now they are giving. BP is still dropped. She's tachycardic. What you will do? So not responding to medical treatment, surgical treatment, started to get DIC because FFP is they are giving massive transfusion. BP is still dropping.
B.
The patient is uterus is open and they have already put the sutures. It is not working. Now the patient is going towards DIC and still the blood, still she is bleeding.
I'm confused between F or Q.
F and
Q.
Q. Okay. F hemostatic sutures they have already put over in the
No, ma'am,
suture.
brace sutures. Brace sutures.
Brace suture. Apart from this, now the it is she is bleeding so much. Even the FFP is being transfused. That means massive blood loss, and blood loss is continued. So this is acute emergency kind of situation. For
Oh,
devascularization, you had to call for vascular surgeon, and in the scenario, you have to take some step actively right now that you can do. So answer is hysterectomy.
hysterectomy.
Yes. If the in this situation, if the patient is not tachycardic, she is not bleeding, that time if facilities are there, that time the systemic devascularization, like Q answer could be there. But the scenario, the patient appears to be bleeding like anything. So you have, otherwise she will die. Hysterectomy. Suturing not helping, patient going towards DIC, so cystectomy, last resort. So gravida 3 has a ventouse birth. So she's on syntocinon drip that is sharing 125 ml per hour. So single most next step. Oxytocin drip she's not is already on.
Narcometric.
See is first
H.
no, they have oxytocin infusion has already started. This is oxytocin infusion. First they will give 5 unit IV. After that ergometrin. After that oxytocin infusion. After that carboprost.
Carbo.
So answer would be carboprost.
Carboprost.
This table you have to remember in chronology because many questions you will find from this PPH guideline. This table is very important. So the patient is in the preconception clinic. Her glycosylated hemoglobin is 9.5%. Retinal renal assessment are normal. BMI is 30. So you recommend to lose weight. What form of assessment to be done before she leaves the clinic? She's not ready for pregnancy. She currently self monitors her blood glucose level by fasting and PP. So the patient is having very high glycosylated hemoglobin, isn't it? And so, what kind of assessment has to be done for her?
Monthly HbA1c.
Yes, very nice. Monthly. So, monitoring the blood pressure, glucose, and ketones before pregnancy. Offer monthly measurement of glycosylated hemoglobin in the women with diabetes who are planning for pregnancy. Okay. Now, diabetic woman pre-pregnancy clinic, glycosylated hemoglobin performed, diabetic and nephropathic assessment done. Comes for follow-up. Glycosylated hemoglobin is 10. She is currently on combined contraceptive pill.
D. Advanced stage pregnancy.
Yes, she should not more than 10, no pregnancy. So, a 39-year-old diabetic woman, not on any contraceptive, attended preconception clinic. Renal assessment is done and albumin creatinine ratio is 36. What you will do? Refer to?
Nephrologist.
Yes. So this is the renal assessment before pregnancy. So kindly refer the woman to nephrologist before stopping contraception. These are the criteria from the guideline. Serum creatinine more than 120 microliter or more, urine use albumin and creatinine ratio more than 30, and GFR less than 45. So in our case, she has got it. This is 36. So the answer is refer to nephrologist before stopping contraception. So woman in maternity triage, 28 weeks of gestation, blood pressure 120, 170, 120, 3 plus protein headache. She all reflexes are fine. You took the blood sample LFT, KFT, RFT, PCR is 140. So, what is the single most appropriate plan of management?
C.
Yes. So you have to admit the patient in like level 2 care, IV labetalol, monitor 4 times a day. So 41-year-old patient, induction of labor at 36 weeks. She suddenly had a headache, swollen feet, blood pressure is 170, 115, PCR is 210, USG shows baby is small for gestational age. Normal Dopplers. Today the blood pressure is 150, 105. The patient is still admitted. So admitted patient, blood pressure to be seen every 15 to 30 minutes till it is less than 160, 110. After that, at least 4 times when the patient is inpatient. Okay, so I could be the answer. The choices from the previous guideline. This is a preeclampsia management. Now the patient is admitted. So patient has a severe hypertension, and so this is a treatment. So you have to kind of remember the table. How would you manage? Because in the exam you will find choices that is appropriate to the new guideline. Okay. Now here the patient has sickle cell disease. Come for preconception counseling. Choose the option single most useful investigation you will offer to her and her partner. Patient saw a sickle cell specialist 2 years back. Now she wishes to become pregnant, so she has come to preconception counseling. She has been examined, not screened for pulmonary hypertension. Decision is taken to arrange. So what you will do? How you will check for the pulmonary hypertension? Which investigation?
Echocardiography.
Yes, that is echocardiography, and this is the according to the new guideline. These are the investigation that has to be done to find out the end stage disease in the sickle cell patients. Any question?
Ma'am, one is there in bulging membranes, you will do circulage. If the question says it's bulging membranes or when exposed membranes, you will do rescue circulage. In bulging membranes, also will do circulage, rescue circulage.
See, actually, the question will give you clear idea how much dilatation. The question is basically incomplete. But ideally, the question will tell you how much is the dilatation and how much bulge is there. Okay, so you follow the guideline, what the guideline says, and you that it usually can be done um, if the membrane, I think if the dilatation is less than 3 to 4 centimeter, just bulging membrane, and it can be done till 27 plus 6 days. So whatever given in the circulage guideline for the emergency or rescue circulage, you have to follow that. Okay.